Wonderful. Hi, everyone. Thank you for joining us today for our diabetes work group. My name is Christy Degner, and I'm a site engagement coordinator for MVC. I look forward to facilitating this work group for you today. Today's diabetes work group will feature a presentation by Gina Schutter of Holland PHO. Gina Schutter has served as the quality manager at Holland Physician Hospital Organization for 8 years. Prior to working with Holland PHO, she was the Medicaid Product Manager and a Population Health Administrator at Priority Health. Gina has a bachelor's degree from Grand Valley State University in pre-med and business. Her responsibilities at work span functions related to quality performance, clinical quality initiatives, and care management. Thank you, Gina, for being here today. Before you begin your presentation, I have a few housekeeping items to review. The session is being recorded. The slides and the recording will be shared with attendees following the work group. Next, we will be monitoring the chat throughout the presentation, so feel free to add questions there. We also will have some designated time at the end of Gina's presentation for Q&A as well. Lastly, your feedback is very important to us. If you could please complete the post work group survey, which will be provided in an email sent following the work group, that would be greatly appreciated. With that, I will turn it over to Gina for your presentation. I'm going to give you control of the screen right now.
Thank you, Christy. I think I've got it. Yep, there we go. Our learning objectives for today are to understand the case for change in modifying our approach and how we manage diabetes. I'll give you some examples of how we're doing that in Holland PHO and what motivated us to make these changes. I'm going to share some information on Blue Cross Clinical Collaborative Quality Initiatives, or the CQIs, related to the management of patients with diabetes. If you're on the hospital side, CQIs might mean a different thing than when you're on the PO side, and I'm going to try and span both worlds here today. And then lastly, discuss some strategies to improve collaboration and care coordination across the network in pursuit of improving outcomes for patients with diabetes. And then tying it all together, how MVC has helped support us in this work and how it's supporting both hospitals and physician organizations across the state. I've got two screens, so I'm between here a little bit, so forgive me for that. To give you an idea of who Holland PHO is, we're a pretty small network in comparison to others across the state. We represent about 156, 180 if you're counting our associate members of primary and specialty care providers. This is kind of what the matrix looks like for physicians and practice sites based on primary care, specialty care, and hospital. Our partner, our H in the PO, is Holland Hospital, and they also have an employed medical group. So 26 of the physicians or 7 sites in primary care are part of Holland Hospital Medical Group, and the rest are independent. We have about 74,000 patients overall across all lines of business and product lines in our PHO, and we use a registry tool called Health Focus that connects aggregate information across from disparate EMRs across our network. To talk about the case for change, our first learning objective, I've got 4 things that I'm going to unpack here. First and foremost, I would say most importantly, building the case for change and management of how we take care of our patients with diabetes is advancements in guidelines, technology, and medications. I've snipped the standards of care in diabetes, the 2023 version here, put that on the screen for you, but the guidelines are overall promoting better medications. They're very expensive medications such as GLP-1s and SGLT2s for their role in weight management and cardiac function. The availability of continuous glucose monitoring, or CGMs, play an important role for patients in being able to monitor and manage their sugars in real time, not to mention how the real-time feedback has helped enhance patient engagement and understanding of their disease process. We also have social determinants that we need to consider, and how food insecurity or food scarcity might impact how we manage patients with diabetes. The second for our burning platform, our case for change, is the increasing illness burden of our population. This is both a PO, these are MVC reports. I've actually snipped our real data. So just to let you know, on the left is Holland Hospital's information, and on the right is Holland PHO's information. These don't show an increasing prevalence of diabetes, though we kind of all have agreed and know that to be true. What this shows is a snapshot of our patients who are presenting to the emergency room specifically from each of these views and what the prevalence of diabetes looks like, as well as what the other comorbidities of this population might be. We're consistently seeing diabetes across all of these categories and in a pretty high frequency. It kind of indicates the right that we have to be concerned about this population, the impact of this disease process on our overall patient population. My third point, let me see if I can pull forward. I have a little bit of a delay. Is greater emphasis on outcomes. If you are part of a physician organization, this scorecard is going to look very familiar to you. This is the Michigan Institute for Care Management and Transformation, or the MICMT scorecard. Essentially, this manages primary care management, and it measures us on how successful our interventions are. So it used to be process measures that we looked at for diabetes. Did we have an A1C completed? Did we have a retinal eye exam done? Increasingly, the focus is now turning to outcomes. What was the patient's last reported A1C value, and what was their last blood pressure of the year? How good we are at keeping them out of the hospital from both an ED and an inpatient perspective. And the last one, sorry, Christy. These slides are a little funny for me. The last one for our first objective is value-based arrangements. This is going to be specific to Holland PHO, but this is a news article that came out earlier this year announcing our partnership with Agilon Health. So while this is kind of our business case, other payers are certainly entering into arrangements with both hospitals and physician systems where they're being held accountable for risk and managing the premium dollar against the medical expenses for their population. Essentially, we're acting more and more like an insurance company, having to manage all of those expenses, the overall care for our entire attributed lives. So this is specific with us with Agilon Health. They are our enablement partner, and it's going to be also specific for Medicare Advantage starting in January for full risk. So rounding it out, or summarize again, our 4 points for building the case for change. What has helped us tremendously in this work is the clinical collaborative quality initiatives that Blue Cross has put forward for us. What they give us, this is kind of the cheat sheet if you want to tune out for the rest of these slides. What the CQIs give us is a structured framework and support for enacting these changes across our network. What we've done is we've leveraged the CQIs to create momentum in Holland PHO, helping to coordinate change on a pretty large scale. What it's going to look like, one more, there it goes. What it's going to look like is kind of this chronological journey. So the rest of my slides are going to start in 2015 and kind of go to current day. It seems at first glance like CQI after CQI after CQI, kind of like a domino effect, but that is not the case. Indeed, it is more like the giant snowball. Our journey really looks more like this. It's an uphill battle, a constant rolling and packing of the snowball with lots of questioning, lots of frustration, lots of compromise, until finally some consistent results that are validating our efforts. It has taken a long time. So I'll take you to the start of our journey in 2015 here on the next slide. There we go. Journey starts in 2015. It probably started before then, but that's when the majority of the PHO's leadership team, including myself, started working here. There was a concerted effort to take our PHO and make it clinically integrated. So we redid everything in terms of our structure and our governance. We had this little thing called care management. There were a couple of them. They were actually housed out of the PHO back in those days. We leased them out to the primary care offices. There were maybe 8 total FTEs. Or 8 total bodies, maybe equating to like 6 FTEs across the network. And we had a sprinkling of community-based programs for patients with diabetes. I apologize, I keep advancing too fast. Our first exposure to the Blue Cross Clinical Collaborative Quality Initiatives was the Michigan Surgical Quality Collaborative, MSQC, and its sister program, MSHOP, the Michigan Surgical and Health Optimization Program. MSHOP was really focused on this idea of prehabilitating or medically optimizing our patients that were presenting for elective procedures at our hospital. A study in the Journal of American College of Surgeons evaluated the MSHOP prehabilitation program. It included 21 hospitals across the state of Michigan that were part of that MSQC collaborative, and it concluded that participation in the prehabilitation program was associated with shorter lengths of stay and lower total episode payments after surgery. While this initiative, this MSHOP and MSQC, wasn't specific to patients in diabetes, through our work in these CQIs, we found we had a lot of diabetic patients. That caused us to take some action related to these patients who were living with diabetes. One of the actions that we took as a result of the MSQC and MSHOP CQI work specific to diabetes or uncontrolled hyperglycemia was developing an algorithm. Our hospital made a decision tree. They set a threshold for A1C or sugars at 8%. So patients presenting for an elective procedure, it included testing and management of sugars. Whereas before it had not. I know we were not alone in this endeavor. Many hospitals also were looking at setting expectations or threshold for A1C. 8% was a little aggressive. I know that was a lot lower threshold than some of the other hospitals in our region, and we know that it delayed elective surgeries for patients. We have firsthand experience in hearing those stories. But what this algorithm also did for us is it aided in diagnosing diabetes for some of those patients who had been kind of considered pre-diabetic for maybe far too long. So it helped with our risk adjustment efforts in that space. Another example of action that we took through the work of the CQIs, this one was not specific to diabetes, but inclusive of it because it ties back to that algorithm that I just showed you. It built on this expectation with MSQC and MSHOP of prehabilitating our patients and pursuing better surgical outcomes. So the PHO developed a guideline for our entire network, and we called it Medical Optimization Prior to Total Joint Replacements. It was very specific to joint replacement surgeries, but it listed in there thresholds for A1C, thresholds for BMI, smoking cessation interventions, and pre-procedural testing that was also tied to Blue Cross's Resource Stewardship Initiative, if you've been familiar with that work. This guideline has since been retired, as many of our practices. We have 2 orthopedic practices specifically in Holland PHO. They've developed their own office-specific forms and kind of customized them to meet their needs. But this served as that first framework prior to those offices developing those forms. Here's some MVC data for you again, camping on that idea of looking at total joint replacements. This is an MVC report from the hospital's view of common conditions. It reinforces the outcomes that we found in MSHOP, that shorter length of stay, more discharges to home, and less cost of care for patients. This specific view is 30-day readmission rates for our joint replacement patients. You can see that your hospital, 1.4%, that was Holland PHO or Holland Hospital's rate in the most recent report dated October 2023. So that one's hot off the press and maybe in your inbox, something to take a look at. Kirsty, I may have lost control. Can you advance them for me? There. Ooh, this one, yep. Going back to that idea of that medical optimization guideline, remember in there I had mentioned that we also had pre-procedural testing considerations for our joint patients. Here's another MVC report that shows our rates of preoperative testing. This isn't just inclusive of joints, it's going to include a lot of other surgeries as well, but it's across all of our patient population. The general learning point here seemed to stick that there are certain elements of clearance for elective procedures that are important, and others might just contribute to more cost. So in these 2 views, I went back as far as I could reach. One's from 2021, but it spans a time frame of 2016 to 2019. And then the most recent report on the right is from 2023 that spans a different time frame from about July 2020 to June 2022. You can see everybody did better. Everybody's kind of trending lower. MVC had a reduction, the region had a reduction, and Holland specifically had a reduction, the greatest reduction, and saw more improvement in reduced preoperative testing across all the procedures. So another reminder too, this relates to the Blue Cross Resource Stewardship. It's another way that Blue Cross rewards POs for doing things right. There's another income stream associated with this, but a different initiative. Go to the next slide for me, Christy. Thank you. So as we're doing all this work in medical optimization, through the work of the CQIs, we found that we needed to develop more ways to support patients further upstream. We added self-management and education classes for our diabetes patients, creating more opportunities to learn more about the disease process, as well as to be part of a program. It was actually like a year-long program to support patients, giving them different avenues to participate, whether that be in person or virtual, or offering that one-on-one support. And then this was a really interesting flyer for us to put out to our network, but we collaborated with our surgeons to offer a free program to patients who were preparing or trying to get ready for surgery that maybe needed some optimization medically. And we created a free surgical optimization program where they could meet with our dietitians and our exercise trainers and kind of get regimented or train like an athlete would. Before a big event, they would train for their surgery. So that was kind of a fun thing that we did there. The next one. Thank you. We also beefed up our care management team. So I mentioned we were dabbling in care management in early 2015. By 2019, we have pretty much expanded care management. We were offering care management across all of our primary care sites, and we were even integrating our diabetes educators into primary care. So about this time, I had sold off every single one of my PHO care managers. The practices were hiring their own. We've convinced them to do that and invest in their own staff. Holland Hospital Medical Group came up with an interesting arrangement, and they leased staff from their Healthy Life programs that was offering a lot of that support. They leased those staff out to primary care to support patients with diabetes. And that arrangement stands today. They have a physical presence in the PCP practices. They've developed really great processes for warm handoffs within the office. They can help with medication assistance programs for some of those expensive drugs. But this is the case today with this leased staff arrangement for the medical group. It's resulted in stronger collaboration across our network. Enter post-pandemic. That was like 2019-ish. Now we're kind of fast forwarding to 2021 because we're going to pretend that 2020 didn't happen. But Blue Cross in 2021 brought the collaborative quality initiatives, more rightfully so, into the physician organization space. In the past, the PHO had been kind of cut out of those programs. The hospitals directly maybe were involved, or the specialists directly were maybe approached by Blue Cross Blue Shield to kind of join in their specialty specific CQI. But in about 2021, Blue Cross started approaching the physician organizations with the idea of the CQI, and they called them Pop Health CQIs. Targeting primary care. So they needed the POs and they needed the structure and the alignment that we brought to primary care. The Michigan Collaborative for Type 2 Diabetes, or MCT2D, was born, and they have three aims really that are focused on increasing the use of CGMs, looking at appropriate medications that include those newer medication agents, GLP-1s and SGLT2s, and then low-carb diet suggestions. We were pretty skeptical at first, but I was able to get 100% of my primary care practices to sign up and jump on board with the MCT2D initiative. Next slide, Christy. Thanks for taking over. When the MCT2D CQI afforded me was a chartered map, or it was like a course that I could take my primary care practices along on. Big benefit of having everybody engaged in the first year. I have had one practice that dropped out. It's a solo practitioner with not a lot of support in terms of administrative support and care management support in their practice. So it kind of made sense with the lift of the requirements of the CQI that they were going to drop out. So I don't have 100% anymore. But we still talk very broadly across our network about the work of the CQIs. So this was an ultimate herding cat scenario, but now with a roadmap that kind of put the PO in the driver's seat, which was really nice. If you're not familiar with the work of the population health CQIs, here's a framework kind of from my point of view, the work that they have for providers. There's expectations that in order to earn an uplift, that's the reward for participating, that providers are going to have to submit case studies. They're going to have to participate in learning collaboratives and some regional best practices sharing through meetings. There's performance and dashboards that are kind of aggregated by a partner called MDC. And then for POs, we have administrative portals where we can monitor progress and completion of all these tasks, partner in monthly calls. And then there's even patient-facing materials. It's payer-agnostic education that practices can use. There's an advisory committee of patients that helps steer the goals of MCT2D along. And then there's fun pilot activities that we can participate in. The Jumpstart one is a partnership with grocery delivery program that offered actually better access to healthier groceries for patients who had diabetes. So it was really neat to participate in that. Through all of this work, as we get deeper and deeper into these CQIs and we start diving into our population, especially now in primary care, it further demonstrates the need to support our patients who are managing diabetes. In 2021, Holland Hospital partnered with Grand Health Partners to be able to offer bariatric services in Holland. Previously, we did not have that service line offering. Our patients who lived in Holland, maybe saw a doctor in Holland, had to go outside of our network to receive that care in the past. We were able to bring that in-house. And then in 2023, just early this year in January, we recruited an endocrinologist who actually just officially joined MCT2D last week. So this big idea that we had was to do more upstream, collaborate more across our network. So if you're a hospital, think about who your provider network is. And if you're a physician organization or maybe part of a practice, think about partnering with your local hospitals. You don't need the H in the PHO to achieve the things that we have done. Leveraging the work of the CQIs and kind of understanding the framework and what the goals are of the different CQIs provides a really natural path for that work to happen. We think that the collaboration could not be more strong without the CQIs. So we're an avid partner in the uptake of them. We keep ourselves very busy with the work of the CQIs here in Holland. And use MVC as a resource to support you in this work as well. It's important for you to understand variation across your network or in your practice, and MVC can help support that work. They have PO-specific reports and hospital-level reports that are pushed out to networks. I have a couple of them highlighted here because they're new. The ED-based episodes push report is a new one, and the SNF and home health push report is a new one to take a look at. Just to plug about their custom analytic capabilities, in the past, Holland PHO and Holland Hospital have requested specific information. We wanted to look at more at CHF and congestive heart failure patients and what their readmission risks were, their comorbidities, and all of the cost of care associated with that population. So we've made some custom requests to MVC before, and they were able to deliver on that. And then participating in these engagement platforms, just being able to share best practices, see what other people are doing, how are they collaborating, how are they able to get leverage on doing new things or doing things differently in their network. And that is the last slide that I have for you. So at this time, I'll open it up for questions. I want to open up my chat here as well so I can see if anything comes in. We covered a lot of ground pretty quickly, spanning the last 8 or 9 years.
Awesome presentation, Gina. Awesome work. Does anyone have any questions for Gina today?
I have a quick question. I am, if for those of you I haven't met yet on the call, I'm Jessica Sova. I'm the engagement manager, new to the MVC team, and that's in part why I have the question. I'm curious about, with the reports that you've gotten from MVC and the things that the data you've been able to get from the registry, could you talk a little bit more about how you have engaged others within your team or within the PHO group with that data? Like, do you use it in presentations, that kind of thing?
Sure. We use it in a lot of different categories and aspects. So with being having an H, the PHO, the Physician Hospital Organization, we have a hospital partner that's kind of part of our family, our 50-50 partnership between the hospital and the physicians. So we kind of have a unique relationship in that way. But when the push reports come into the hospital team sends them to us. And when the push reports come to the PO, we send them to the hospital. So we kind of compare notes and have an interesting collaboration there with regard to the dashboard opportunities. I also have a different view where I'm able to toggle between if I want to look at certain hospital aspects or PO aspects. It is a little bit different for our region too, because we're kind of an island unto ourselves here in Holland. We don't have a ton of regional competition. You can't go further west, you're going to run into the lake. East, we have the Corwell system. We have Trinity to our north, but for the most part, our patients here in Holland are receiving services from Holland Hospital. So we do have a pretty healthy overlap in that regard. A lot of times we will look at the MVC data to tell ourselves a story. So it's kind of like Brene Brown, you know, the story that we tell ourselves is we've done all this work, we expect to see these outcomes. A lot of times we'll look to MVC reports to validate those outcomes, and we'll look at it both from the view of the hospital and the physician organization, because it's important to consider, you know, what aspects you're looking at. Is it readmissions? Is it cost of care, episodic cost of care related to hospital stay, or is it more on a population basis? Because they kind of feed off each other. So does that answer your question, Jessica?
Sorry, I forgot I muted myself. Yeah, no, that answers my question, and I really love that answer. I wonder if there's anybody else on the call who's maybe from the hospital side that's working with their PHOs in a similar way, or vice versa in other parts of the state. And if not, I think that's definitely something that I would like for us to try and strive for.
I think we have a weird advantage having the H partner. So I recognize that that is not the case pretty much for the rest of the state, but I would encourage it to the extent that you are able to use the work of the CQIs, understand the work of the CQIs, both from a hospital and a specialist perspective, as well as a primary care perspective, because the primary care CQIs are brand new, but we can help each other. I mean, at the end of the day, I think all of our objectives are aligned with better care at the right place, at the right time, and at the right cost. And so if we can work together and kind of leveraging like what each of those CQIs, what we're going to be focusing on, we can create a lot more momentum and positive change with better outcomes.
Yeah, that's what we're all here for. Thank you. Let me see if anybody else has questions.
I was interested when you were reviewing the free surgical optimization program that you had. Did you look at any outcomes afterwards to see if that like directly impacted anything, or how was kind of the buy-in for that? Like, were people very interested in attending that program?
For the MSHOT program and MSQC, our joint surgeons were really bought in. They were partnering in the surgical collaborative, and I think MSQC was really pushing the MSHOT program because it had so many hospitals across the state that were going to be doing it. So in a facility specific way of looking at outcomes, we experienced delays with surgeries. We saw a lot of patients, and it was this tug of war. So patients with diabetes that were maybe overweight, that maybe needed a knee replacement because of their diabetes and their condition, all their comorbidities, couldn't get that knee replacement to maybe participate in the aspects of a healthier lifestyle. So it was this push-pull of what do we do first, chicken or the egg kind of deal, that wasn't always the best thing that you don't want those situations to arise. But when you can get everybody to the table around a guideline or around a program like prehabilitation and say, this is what's best for the patient. If we can hold off on this surgery, if we can get them to a better spot with their BMI, if we can get them to a better spot with their sugars, the surgical risks of the procedure are going to be down for the hospital. They're going to win. The operating physician, the surgeon, is going to have reduced risk exposure. The patient's maybe not going to relapse to their office with a bunch of complications. They're going to win. And the patient in primary care should, in this example, have such a life-altering surgery in this way, being able to participate more fully in the management of their health is going to win. So kind of saying it's going to be a win-win-win situation if we can get everybody to agree on certain aspects of the care. It was difficult, but those are the conversations that we had to have. And then being able to support each other in those ways. So the primary care was saying, you can't possibly dump all these patients back to us to manage better before we can send them to you. You know, how is that push-pull going to work? We need them to have this joint replacement so that they can participate in a healthier lifestyle. And having the programs put forth by the hospital was important. Having the care managers available in primary care was more important. And all these things kind of had to be orchestrated or happen at the same time in order for everybody to really feel the full benefit. So it wasn't like one led to another. It wasn't one bottleneck producing another bottleneck. It was more of that coordinated effort, kind of thinking larger scale. And that's really the beauty of what the POs do. We kind of are that strategy setting organization that sits back at 30,000 level and says, okay, what's happening here? What's happening here? How can we work together?
Definitely. Thank you. Great answer. Does anyone have any other questions for Gina? Okay, wonderful. Well, we can go ahead and wrap up for today if no one else has any other questions. Thank you again, Gina, for joining us today. I have a few slides before we conclude, so I'm going to go through those now. So I just wanted to review some upcoming events that we have for MVC. We do have a health and action work group focused on rural health on November 15th from 11 to 12 p.m. We also have a cardiac rehab work group as our first work group in December. That will be on December 7th from 2 to 3 p.m. And then our other work group for December will be a chronic disease management work group, and that will focus on post-discharge follow-up. And that will be on December 14th from 11 to 12 p.m. You can register via the link that will be provided in these slides following the work group, and you can also download our events calendar on our MVC website to register for all of these work groups as well. So with that, thank you again for joining us. As a reminder, the work group slides and the recording will be shared with the registrants following the work group. If you have any questions at all, please reach out to us. Thank you again for your support of MVC, and we look forward to seeing you at future events. Thank you again, Gina, for a great presentation.
Thanks, Christy. Thanks for advancing my slides when I was having difficulty.
Absolutely. Have a great day.
You as well.
Great job.